Welcome to this podcast from Neurogastroenterology and Motility. It publishes original research and topical reviews on basic and clinical aspects of gastrointestinal sensation and motility, as well as brain-gut interactions.
Welcome everyone to this month's discussion of an interesting article published in the current issue of Neurogastroenterology and Motility Journal. My name is Dr. Purna Kashyap. I'm a gastroenterologist at Mayo Clinic in Rochester, Minnesota. It's my great pleasure to welcome Dr. Michael Camilleri, my colleague at Mayo Clinic, who really needs no introduction here. Dr. Camilleri is a consultant in the Division of Gastroenterology and Hepatology at Mayo Clinic in Rochester, Minnesota, and is a professor of medicine, pharmacology, and physiology at the Mayo Clinic College of Medicine. His research interests have spanned the clinical enteric neurosciences, gut neurohormonal control, obesity, irritable bowel syndrome, and pharmacology and pharmacogenomics. His work has been funded by the National Institutes of Health. He has received numerous awards and honors, and recently published a paper in Neurogastroenterology titled "Straightening the Road to Rome" in our journal. He joins us to discuss his thoughts from this commentary. I will point out that Dr. Camilleri has served as chair of the Rome 4 Committee on Pharmacological, Pharmacokinetic, and Pharmacogenomic Aspects of Functional Gastrointestinal Disorders, and was a member of the Fundamentals of Neurogastroenterology, Physiology, Motility, Sensation Committee. Welcome, Dr. Camilleri. You've brought up some really interesting and perhaps provocative ideas about tweaking the current approach to Rome criteria as they apply to IBS and maybe more broadly to functional gastrointestinal disorders. I want to just start by asking what led you to write this important commentary, and more importantly, the timing as to why now?
Thanks, Dr. Kashyap. It's a pleasure to provide some of this commentary. You know, we've now had 4 versions of the Rome criteria for irritable bowel syndrome and other functional gastrointestinal disorders. And over the last 30 years, I've observed and studied these sets of criteria and seen how they've been appraised in the literature for their performance and their utility in clinical practice and in epidemiological studies. I think it's important to remember that the original intent was for these criteria to be used in clinical trials. And I think that's where they have been very, very helpful in terms of eligibility criteria. But as I was thinking through this series of 4 sets of criteria, there were 4 main reasons why I felt it was important to provide this commentary. First of all, you know, several validation studies, and we can go through these in some more detail later, and I do so in the article. These validation studies have identified that there are certainly deficiencies in the criteria. Secondly, they've become rather unwieldy in the clinical practice. And I think that there is more and more evidence from clinical studies in particular and mechanistic studies that would suggest that simple identification of a predominant symptom could be advantageous. The third is that in the 30 years since the first Rome criteria were published, there's been a heck of a lot of advance in the diagnosis of what I call the organic dysfunctions of these disorders of gastrointestinal function. In other words, understanding the mechanism, which then provides an opportunity for more specific and perhaps individualized treatment. And then the fourth is that, you know, despite the laudatory objective of their use in clinical trials, there has been what I call mission creep into the clinical diagnostic practice. And many studies, and I will particularly mention those of Paul Moayedi and Alex Ford at McMaster University, have proven the performance characteristics of the criteria is suboptimal. And if you add some questions like the presence of nocturnal diarrhea or screening for blood and stool parameters like hemoglobin, C-reactive protein, calprotectin in the stool, they considerably enhance the criteria. So I felt it was important for these 4 main reasons to appraise where are we now, to find our best way to try to move forward. And I felt that there was an opportunity to simplify and also therefore to straighten the road from the Rome criteria.
Thank you so much. That provides a really nice perspective and you know, why we need to discuss these more openly at this point. And I see that you already highlighted some of the important areas. So I want to go through some of these points which you've highlighted in the commentary, starting with this idea of splitting versus not splitting symptom complexes into different diseases. As you mentioned already, you've seen the Rome criteria evolve over the years, but most of our listeners may not have. So can you tell our listeners who may not be aware of how these have changed and some of how this has impacted the field in your opinion?
Thank you again. So I think there have been two major sets of changes. The first important changes occurred with Rome 2. And the main thing that happened, I think, in Rome 2 was what we might call the splitting off of symptoms that were not necessarily or consistently associated with pain. So yes, by all means, we're all going to think of irritable bowel as pain in the presence of alteration of bowel function. But in Rome 2, we started to see an effect, in effect, a redundancy, if you wish, of diagnostic categories. So just as an example, to make that point, from irritable bowel with constipation, we now evolved into functional constipation as well as irritable bowel with constipation, and similarly for diarrhea. Now, the evidence, and in fact, one of our colleagues at Mayo Clinic did a lot of this work, may he rest in peace, Dr. Locke, did some works in epidemiological studies here in Olmsted County, Minnesota, showing that within the same patient, there will be overlap of symptoms. And we all know this. Patients will have functional constipation and symptoms of functional dyspepsia or reflux disease. So these are not discrete symptom complexes that do not exclude other disorders. And the second really important point, and Smita Halder and Rick Locke were the key investigators, but subsequently, other work done from Chapel Hill, North Carolina also proved this to be correct. There's transition of the same patient between diagnostic categories. And the commonest transitions would be between irritable bowel with constipation and functional constipation, or irritable bowel with diarrhea and functional diarrhea. So that was the first major effect of splitting off these symptoms, that the same patient could end up being in different categories depending upon whether you seek the symptoms at one time or another. Now, what also happened as a consequence of this, and we're still talking about the whole issue of splitting of diagnostic categories, is that essentially the drug development programs for drugs, let's say, in irritable bowel with constipation, functional constipation, for lubiprostone, linaclotide, plecanatide, and tegaserod, these had to be basically duplicated because the FDA then required proof of efficacy, not only in IBS constipation, but also in functional constipation or vice versa. So that was the main impact, I think, on our field as a whole in terms of the splitting off of symptoms with Rome 2. In Rome 4, the major change that I have noted, and we've had at least 4 or 5 papers document this in the literature, is the change in the definition of pain. We've lost the term discomfort. We use only pain. And what's basically happened is that mostly patients with significant somatoform disorder or psychological disorder now have a big overlap with irritable bowel syndrome. And so here we're getting to the point where, let's say, a patient who does not have such a severe form of pain with frequency of pain rather than discomfort might not be eligible for the diagnosis of irritable bowel. And that might impact whether that patient would be allowed to receive a certain medication because they fulfill the criteria. They might have insufficient criteria on the pain scores to be able to be eligible for medications that are actually approved by regulatory agencies based on Rome 2 or Rome 3 criteria. So I think that was another consequence in our field in general.
I see your point about how these changes not only affect the trials, but also bleed into clinical practice, as you mentioned here. Then you bring up the idea of subcategorizing diseases using symptom-based criteria and some of the potential pitfalls. Can you elaborate on that?
Yeah, I mean, the one that's most apparent to me in terms of pitfall is that we've become much more aware, and by we I mean everybody who practices in the field of neurogastroenterology and functional GI diseases, that the symptoms of excessive straining and sense of incomplete rectal evacuation, which are part and parcel of functional constipation as well as irritable bowel with constipation, they are very good symptomatic markers for rectal evacuation disorders. And in fact, many years ago, we identified that in patients with rectal evacuation disorders, the main symptoms are constipation, excessive straining, sense of incomplete evacuation, secondary bloating, and left-sided abdominal pain, which is relieved by having a bowel movement. Whoa, those are exactly the symptoms of IBS with constipation. So, the fact of the matter is that by some of this, what I would call imprecision in some of the criteria, especially as they relate to constipation, we've had a loss of opportunity to identify from symptoms those patients who will require a completely different type of treatment, because Satish Rao and others in North Carolina and in Italy have shown that in fact pelvic floor disorders respond best to biofeedback retraining, not diet or changes in pharmacology in terms of treatments. So I think this has been a time where we need to go back and ask ourselves, have the diagnostic criteria really helped us identify those patients, or has there been an overlap between these different phenotypes? But it's important for us to recognize those diverse symptom phenotypes so that we can do the tests that are required to make the diagnosis and then provide the specific treatment. In this case, biofeedback with retraining of the pelvic floor and muscle relaxation.
That's a great point, Michael. And I may go on a tangent here for a bit, but so when we considering clinical trials and trying to recruit patients with constipation predominant irritable bowel syndrome, do those trials then actually exclude patients with evacuation disorders, or they are included as a part of those?
That's a superb point, Perna, because one of the things that we can tell is that for most of the phase 2b and phase 3 trials, those patients are not excluded. And when you actually look at, let's say, the proportion of patients that actually respond to treatment, even if you don't use the 9 out of 12 week requirement of the FDA for both, the symptom of pain and the symptom of bowel dysfunction to be improved, if you look just at, what is the proportion of patients that have, let's say, at least 4 or 6 out of 12 weeks of improvement of constipation. Let's take constipation because that's the easiest example. The maximum percentage that actually achieve that goal on active treatment is never above 70 or 75%, which to my mind has always indicated that perhaps 25 to 30% of the patients are by definition going to be non-responders, because if you just give a prokinetic or a secretagogue to a patient who's got a rectal evacuation disorder, you should not necessarily expect that that patient is going to respond to treatment. And therefore, it almost abrogated the percentage of patients that are likely to respond to treatment, because these patients may have had, and in many practices, 30% of patients with functional constipation or IBS constipation actually have a rectal evacuation disorder. So you're by not excluding these, by having them in the study, you kind of have a mismatch or a mixed population of patients that may not respond to the pharmacological agent that you're trying to use to help either motility or secretion.
That's a great clarification, I think, and we'll come back to this towards the end of the talk. But I think in some ways, the companies should also have a vested interest in this, because it's in fact, decreases the efficacy of drug because of the way we are subselecting patients, or at least decreasing the perceived efficacy. Finally, you bring up the impact of variable pain severity, and talked a little bit about it in the earlier parts of this podcast. But you talked about the impact of variable pain severity in different Rome criteria, and can you help explain this to our listeners?
Sure. So in Rome 4, the pain severity is required to be pain, not discomfort. That's the first point. And also, it has to be at least 1 day per week, and the pain has to be present for a period of 6 months. So what happened there is that there have now been at least 4 studies that I know of, and they've come from different countries. One came from a combination of United Kingdom, Canada, and United States. Another one comes from Scandinavia. Another one comes from the United Kingdom alone. They've all now demonstrated that the patients who fulfill Rome 4 criteria, first of all, there's a much lower prevalence of patients who fulfill IBS criteria based on Rome 4. It's essentially been about 50% of the patients that would otherwise have been identified with, let's say, Rome 3 or Rome 2 criteria. But the other thing that is really relevant is that when you look at the other symptoms that these patients have, they very much endorse somatization disorder and psychological disorders. So it's almost like these are patients who might have more of a brain dysfunction, if you wish, rather than a peripheral gastrointestinal dysfunction as the cause of their symptoms. And that may also be another reason why, if you have a medication that's targeting the periphery, whether it's, let's say, a peripheral visceral analgesic or a medication that targets bowel dysfunction, the likelihood that the pain component in these patients with prominent somatoform and psychological disorders, the likelihood that they're going to respond to a peripherally acting agent, I believe, may be even lower. So we might see even an impact on the outcomes of clinical trials as the Rome 4 criteria for IBS are applied for recruitment and for eligibility.
Thanks, Michael, for clarifying all of those points. And but moving to a more practical side at this point, the initial motivation for Rome criteria, like you mentioned, was to develop uniform cohorts so we can do clinical trials to help develop new therapeutics. And we have to all agree that this was successful. We do have good therapeutics now compared to 20 years back. And but over the years, these iterations of these criteria have affected drug development more broadly because of the cycle or the time it takes for drug from inception to coming to market. And more specifically, how has this impacted the management of patients with functional gastrointestinal disorders in your practice? Because there's also been advances on the mechanistic aspect of these diseases.
Yeah, so I just want to make a comment, and you appropriately stated that the presence of these eligibility criteria have enhanced clinical trials, and I think from a regulatory perspective, that is appropriate. Of course, we don't have a control group. In other words, we don't know whether drug development programs would have been less expensive or more efficient if, in fact, there had been a different approach that perhaps had used some of the perspectives that we've just discussed here. In other words, the predominant symptom, the presence of some biomarker in order to identify subgroups. And I think this is where I believe we need to move. We have learned that there is significant transition and overlap within the dominant bowel dysfunction. And we said it before, IBS constipation and functional constipation. We also determined that we can enrich those study populations by excluding the patients with rectal evacuation disorder. All of that is eligible with a good history, a good clinical examination, digital rectal examination, and also some of the valid tests like anal rectal manometry with balloon expulsion. But let's go beyond that, because 30 years, as I said, have passed since the first iteration of the Rome criteria. And I believe that we have subgroups of patients, whether it's by history in terms of the post-infectious irritable bowel syndrome patients, or it's by transit measurement. We showed many years ago in a prospective study of more than 120 patients that about 40% of patients with constipation predominant IBS diarrhea predominant IBS will have accelerated transit. That 20% of patients with IBS constipation have delayed colonic transit. We've now been able to show that anywhere between 20 and 50% of patients, and this is the entire literature, not just our studies at Mayo, but 20 to 50% of patients with diarrhea predominant IBS symptoms have bile acid malabsorption. So there are actionable biomarkers that then could lead us, even in our practice, to identify more individualized therapies directed at the dysfunction that's causing the patient's symptoms. So my idea is that let's think about the predominant symptom. By all means, let us give first-line therapies, which are pretty standard: fiber for constipation, an opioid for diarrhea, perhaps an anticholinergic or a central neuromodulator for pain. But if the patient does not respond to those first-line treatments, let's think beyond just saying, okay, we have symptom diagnostic category. Let us try to identify the mechanism with often non-invasive tests that have been nicely validated. We've actually published data on the likelihood ratios as well as the sensitivity specificity of a variety of actionable biomarkers in relation to functional gastrointestinal diseases. And I think that is the way in which we can straighten the road from Rome. Use simplistic approaches with predominant symptom, give a first-line therapeutic approach, but then move in those who do not respond to identify the dysfunction so that we can be more effective in individualizing therapy.
Great. And I think this has been a really nice discussion in terms of your commentary on how to straighten the road to Rome. And I know you've made a lot of points. And I was wondering if you wanted to add something, or you want to break it down and summarize for our listeners in terms of the key approaches that you would recommend in terms of how to modify this without taking too much more time.
Right. Well, so I mean, the main point I think is to focus on what's the predominant symptom, to give a therapeutic trial with first-line therapies. If the patient doesn't respond, think of using some simplistic approaches that identify non-invasively as much as possible the mechanism that's causing the dysfunction, and then target that with the pharmacological agents that are available. I want to finish off with one point. When in my clinical practice, one of the most rewarding experiences has been in being able to explain to patients what is the specific dysfunction that we are identifying. And you could almost sometimes see the patient become quite emotional because at last there is a straight road. And the patient says, "So doc, it's not all in my head after all, huh?" I think that's what keeps me encouraged that we should continue to work to perfect all the good work that's come from the Rome criteria, but to move beyond it and to move into our understanding of physiology, pharmacology, and get those diagnostic tests to become much more easily available and implemented at more centers around the country and around the world.
And so, that's I wanted to bring that up as my sort of last point, and at the risk of being controversial, because I think, like you said, 30 years back when we started thinking about these criteria, it was a way of forming cohorts for clinical trials. But of course, science has advanced. We have learned a lot as a result of Rome criteria in terms of individual dysfunction. And so the question, again, not sounding too controversial, is to whether it is sufficient to try to straighten the road to Rome, or should we also be concurrently thinking of alternate strategies to stratify patients beyond just symptom-based diagnoses, where we can stratify them based on underlying mechanism, which could allow for more targeted therapeutic development in subsets of patients, and may also be more rewarding in terms of clinical trial effects that we see with individual drugs. And is it a time for change, or we should stay in this hybrid zone, or you think we are way past that point for change?
Well, I mean, I think there is an opportunity for us to change. It will require commitment and participation. especially within the context of the neurogastroenterology and motility field, but also in participation and in collaboration with our colleagues and ourselves who are also part of that Rome initiative. So this is intended to be a positive way for us to continue to enhance not only the clinical trials, but also to have an impact on the clinical management of patients.
Great, thank you so much. And it's really nice for you to take the time to share your thoughts. With that, I would like to thank you, Dr. Camilleri, for your excellent commentary and assisting us with the podcast this month. And now we have Dr. Tack and Dr. Magnus Simren, who wrote an editorial trying to provide perspective around that commentary from the Rome Foundation perspective. Dr. Tack is a professor in internal medicine and the head of Department of Gastroenterology at Leuven University Hospitals. He's a principal researcher in the GI Motility and Sensitivity Group in the Translational Research in Gastrointestinal Disorders Unit at the University of Leuven. Professor Tack's research spans diverse topics, which includes pathophysiology and management of gastrointestinal functional and motor disorders. Dr. Tack is the president of the Rome Foundation. Dr. Magnus Simren is a professor in gastroenterology in the Department of Internal Medicine and Clinical Nutrition in the Institute of Medicine at Sahlgrenska Academy at the University of Gothenburg. He's a head of Neurogastroenterology unit there, and his research focuses on the pathophysiology and treatment of functional GI disorders, as well as the importance of brain-gut interactions in these disorders. Dr. Simren is a board member of the Rome Foundation. Thank you so much, Jan and Magnus, for joining us today to share your thoughts on the recent commentary by Dr. Michael Camilleri. While there are varying opinions on the application of Rome criteria, there is unanimous agreement that the Rome criteria have been instrumental and critical for the development of therapeutics for functional bowel disorders. We've had a chance to talk to Dr. Camilleri earlier about his commentary and his opinions about what needs to be done to help straighten the Rome criteria. And now we look forward to hearing your thoughts. You have outlined some important points in your editorial that balance out the comments made by Dr. Camilleri. And before we go into individual sections, for the benefit of our readers, I wanted to ask if you can give us a brief overview of how Rome criteria are developed and how this process has evolved over the several iterations to where we are currently now with Rome Pro criteria. Jan, go ahead.
Thank you. So not entirely reflected in their popularity, but the functional GI disorders make up the biggest group of patients in clinical practice. About half of the average GI practice is dedicated to patients with a disorder of gut-brain interaction. And also at the population level, this is extremely prevalent. So and this is actually very nicely shown in the recent global epidemiology study that Rome conducted, which is in press for the January issue of Gastroenterology. So with so many patients, you need a system to organize them and to subdivide them in meaningful entities. And the approach that Rome has taken initially was an anatomical subdivision. There are functional disorders of the esophagus, the gastroduodenal region, the bowel, the anal rectum, and so on. And within these regions, there's also different entities recognized based on symptom clusters that occur together. Now, both the anatomical subdivision and the clusters in there, for instance, functional dyspepsia, for instance, painless constipation, for instance, irritable bowel syndrome, are supported by epidemiological research. Not only the global epidemiology study, but also older research. For instance, the 20-year-old now US householder survey, which actually identified a lot of the symptom complexes that we have delineated and given names in the Rome process. And so their existence is established both at the population level and also in clinical practice. If you do factor analysis on a patient cohort, you find most of the Rome-based definitions there. And as we now know, there's also specific treatments for many, not all of them, but many of these entities. So I think that is actually the historical process. Anatomical subdivision later on supported by analysis of large-scale data from practice and the general population, and later on supported by the development of therapies for specific disorders, for instance, IBS.
Thanks so much, Jan. That's really nice to get that perspective. Now maybe you can go into the editorial, and Magnus, maybe you can help us with this. Let's start with the idea of splitting versus not splitting symptom complexes into different diseases. What is the rationale, and what do you think about the pros and cons of this approach?
So thank you for this question. I can follow up on what Jan already said. I mean, there are a lot of epidemiology studies supporting that actually dividing these different disorders into, these symptoms into different disorders is valid from an epidemiology point of view. But there are also a lot of pathophysiology studies that actually support the existence of different diseases, disorders based on different symptom combinations of symptoms. And also when it comes to response to treatment, there are also evidence supporting that we should actually divide these symptom complexes into different diseases, disorders. The problem, of course, with this approach is that patients can move in and out of these disorders. And in the recent update of the functional bowel disorder definition of Rome 4, we acknowledge that there is a move of patients moving in and out of these disorders, and we see these disorders as some kind of continuum or spectrum. So I don't think the system is perfect, yes, but I think at this stage this is the best that we can have based on the current knowledge based on pathophysiology, response to treatment, and epidemiology. But we acknowledge that there are pros and cons with these approaches. But from a clinical perspective, it's useful, as we will come back to define specific disorders based on combinations of symptoms.
Thanks, Magnus. And Jan, if you could address this evolving discussion around subcategories, and to give an example, which you mentioned in your editorial about rectal evacuation disorders as being a subset within those diseases related to constipation, and are unlikely to respond to pharmacological treatment. And more specifically, how does this affect clinical trial results? And are we stacking the odds against ourselves by including them and knowing that a subset of patients may fail this? And then how does this affect clinical management when we tend to categorize these patients?
Yeah, I think that it's a very valuable remark. And I think as clinicians in advanced care, we're all keen on detecting rectal evacuatory disorders because we can treat them with targeted biofeedback and actually cure them, which is not the case for most of the constipation. However, if you take the general population view on constipation, this is 11% of the population that fulfills the Rome criteria for chronic constipation. This is a huge amount. Most of these are managing themselves with advice from a pharmacist or are seen in primary care. And I'm not sure in primary care that you can really recognize this because there is no gold standard. We do balloon expulsion tests. This is hardly used. And actually, a Canadian study showed that only 1/3 of the advanced care centers actually offer the balloon expulsion test. So in primary care or at a pharmacy, this is never going to happen. Second is some expert views have actually expressed the idea that the best way to detect this is a clinical rectal exam in the hands of a very experienced, dedicated gastroenterologist dedicated to rectal evacuation disorders. The average clinician, the average GP will not do this. And there are no questionnaire which has any validity in increasing the likelihood of detecting or diagnosing rectal evacuatory disorders. And finally, the best treatment in advanced care is the biofeedback, as I alluded to, but to apply this to, let's say, maybe half of the 11% of the general population who has chronic constipation is not feasible. There's very few practitioners who are experienced with it. The GPs do not know how to diagnose it, so how to refer for it. This is in many countries not developed. There's no reimbursement. There's no practitioner who really does this on a large scale. So I think it's very difficult to organize this for the bulk of patients with chronic constipation who are there. And actually the studies we have not distinguished this group. The easiest studies, the polyethylene glycol treatments for chronic constipation, there's efficacy over placebo. Overwhelmingly, very convincingly, nobody tried to rule out rectal evacuation disorders, but they work in a substantial proportion very well and much better than placebo, even for more complex treatments. The studies with linaclotide for chronic constipation, for instance, the studies with prucalopride did not rule out rectal evacuation disorder and actually showed a meaningful and robust margin over placebo, allowing them to be approved at a regulatory level. And even a post hoc study, surprisingly, a series from Anton Emmanuel in London, paradoxically showed that there was a better response to prucalopride in those who had a rectal evacuation disorder shown by a balloon expulsion test compared to those who had, for instance, slow transit. So it's not always predictable at the very specialized level. It is not done at a large clinical trial level. And I think if you have a good efficacious treatment for constipation, you don't need to distinguish them. And at the primary and general population level, it's impossible to find this group. There's no gold standard. Even if you want to develop it, it's very elaborate. And the focused treatment is not available, but actually the first-line treatments work very well without making the distinction.
Thanks, Jan. And really also important to bring back the point that we think of being in the US or in Europe, we forget that there's a large population outside of these developed countries where we don't have as many resources. And I think it's a good reminder that we need to consider the entire geography and not just the developed world. Magnus, you worked on changing, you worked on modifying the current iteration in terms of incorporating pain severity, and there's been a lot of discussion about how this has changed the epidemiology or changed the patients who fall within that. So it'll be helpful if you can elaborate on the rationale for this and what's the path going forward around this.
Yeah, when it comes to defining IBS, the main change that can explain the reduction in prevalence in IBS, Rome 4 IBS versus Rome 3 IBS is the frequency threshold for pain, which actually explains the large difference there. And the background to that was that that was based on a normal populations-based study in the US to define a threshold to define a clinically relevant population. So that is the background to this. The use of that we use 1 day per week as the frequency threshold. And when it comes to relevance in clinical practice, I think this is, at least from my perspective, the majority of patients who actually, the subjects who actually come to a clinic with what we call IBS today actually have pain. And there we include pain as the main treatment target. But if you don't have pain and only have bowel habit abnormalities, you target the bowel habit abnormality anyway. So there we have another approach. So defining a group with pain plus abnormal bowel habit has a bearing for the clinical management of these patients, because there you have to include pain in your management. But whereas patients with only bowel habit abnormalities, there we target the bowel habit abnormalities. So that was one of the rationales behind splitting off these different groups in Rome 4. So one group with pain plus abnormal bowel habit, which we now call, which is IBS, where pain is very important to consider when you treat the patients in conjunction with the bowel habit abnormalities, and the other non-pain related functional bowel disorders, where you focus on the bowel habit abnormalities per se. So that was a short response to this. I mean, it wasn't an easy decision to make, and whether we got it 100% right, I don't think anyone is sure of that. Probably future studies have to show that, and that's actually how Rome has evolved over time. There are some changes made, and then we need to evaluate also in prospective studies whether these changes are valid or not, and then that's why we have new iterations of these criteria as well.
Thanks, Magnus. And actually that ties in nicely to my next question, which I was going to base around this, because as you mentioned, as new data becomes available, the Rome criteria get revised and you have a new iteration. But when clinical trials are done, they're done using a specific Rome criteria. So, as this example, if pain became a classifying category and a previous trial had approved a treatment based on that, what happens when the new Rome criteria come by? Are those treatments still valid in this population because the criteria have changed and they use the previous criteria, or we have to think of redoing a clinical trial with the same therapy? Jan, you can go ahead and answer.
I can
Magnus
start
can.
because I can start with that, and then Jan can follow up, because I mean, it's important that we are, I mean, is to say that we are not, I mean, defining a totally new group with Rome-4. We are narrowing down the group a little bit, and we are probably focusing more on patients rather than what you can call a community IBS. That, I mean, that, so if we look at our population, for instance, seeking healthcare in Sweden, the majority of patients who had IBS with Rome-3 actually have also IBS with Rome-4. So what the group that we probably leave out may be more community-based IBS subjects who hasn't sought healthcare, and that's therefore I think these treatments are valid, and many of them also are accepted both for the painful functional bowel disorders and the non-painful functional bowel disorders. Linaclotide, for instance, approved both for in most countries for both IBS with constipation and functional constipation. And maybe that was just a follow-up on the previous discussion, but maybe then now Jan can continue on that topic.
Yeah, and I think as a clinician, you need to be aware of drugs or other treatments that they use, of the scope of their activities. And you know, I think we all have in mind when we prescribe a drug, like the type of patient that would best fit the picture for that drug. I mean, we don't have a single treatment for IBS with constipation. We don't have a single treatment for functional diarrhea. We have many categories, and actually we choose there which one to put forward. And this is based on two things: the clinical profile, and we'll get back to that later, but I think it means the multidimensional clinical profile. So the whole scope of the patient presentation and disease history. And the second thing is your knowledge of what a drug is best at. For instance, if you have a drug for chronic diarrhea that mainly works on the number of bowel movements, you will use that in a patient who has a lot of bowel movements and where this is bothering him or her throughout the day. However, if you have a drug that would actually control the urgency aspect of it, and if this is a patient with urgency incontinence, the second drug will be the one to choose primarily for that patient. So you need to know the history of drugs, what they can do, and then whether criteria change over time, and I think they will continue to change, should not drive your usage that much. You know the clinical profile of the drug, what it can do, you choose based on the patient profile, and you go for your best choice. And I think that is the key of clinical medicine in practice, actually.
Great, thanks Jan and Magnus. I think that was that's a great discussion on this topic, and I think also, as you mentioned in your editorial, these diseases represent a continuum, and so even if patients, what I'm hearing is that even if patients fall out of one category, they would still be in this continuum for which there are medications. You just may have to switch the medications that would be appropriate in this instance. So, you know, getting towards the end, Magnus, moving more to the more practical side, the initial motivation for Rome criteria was to be able to develop these uniform cohorts, which can be used for clinical trials to help develop new therapeutics. And I think nobody would argue that as a strategy there, we have been very successful. We actually have multiple approved treatments now for functional gastrointestinal disorders. And now, as we are evolving with the new iterations of Rome criteria, how do you think this affects clinical practice more for what you just referred to as community IBS or community practitioners, and also for specialist gastroenterologists beyond just their role in clinical trials?
I think, and from my clinical practice point of view, I think it's very important to give the patients a diagnosis. I see many patients coming to our unit who has just, where they have been labeled as having IBS just because the referring physician doesn't really understand what is going on. And And then the patient goes to the internet and he or she looks IBS up and say that this doesn't fit at all with my symptoms. So therefore giving the patients an appropriate label of their symptoms is very important in order for them also to understand what they are suffering from, and to also to have a trust in the physician, because there is so much out on the internet today. So if they search for a specific disease that they've received the name from their physician and it doesn't fit with what is on the internet, it really ruins the patient-physician interaction and the relationship. So I think from a physician-patient interaction, I think it's very important to be able to give the patients a more directed or a specific diagnosis than just saying you have a functional gastrointestinal disorders, we don't really know anything about it, but to focus it down, narrowing it down, and by that also justifying use of different drugs, and also justifying or explaining what are the mechanisms behind symptoms, so they can follow what is written on the internet, etc. So I think it's very important to be able to give us more specific diagnosis to the patient. I think that has helped me tremendously in my clinical practice, and I testify that there are also many other colleagues who agree with me on this.
Great, thanks, Magnus. And you know, before we end, I was wondering if both of you, in your opinion, can give us a view over the horizon of where do you think we are headed? What do we have to look forward to in the coming years?
Yeah, maybe I'll start on that. A little bit forgotten, I think, but we're going to focus on it and make it more visible. Is an innovation concept that was introduced already at Rome 4, which is called the multidimensional clinical profile. Because actually we can categorize patients according to criteria and say this is chronic constipation, this is IBS mixed. And then that should actually dictate the next course of actions of the clinician, but this is not really the case. If you have a patient like that, you need a diagnosis, of course, but then you look at other aspects. And Rome has actually thought about this and put forward what is called the multidimensional clinical profile. So it says one thing that drives your clinical management is the diagnosis. Let's say IBS type mixed. And then there is a clinical modifier. That is the second dimension of the multidimensional clinical profile, which will drive further choices. For instance, this could be a post-infectious onset, mixed IBS. Or it could be somebody who says, I tried a low FODMAP diet and I'm like 50% better. So that's a clinical modifier. The third one is the severity level. If a patient has IBS symptoms and says, you know, it bothers me like 2 or 3 times a week and I would really like to know whether I need to be worried about that. But you can have a patient with the same diagnosis who says, I've had this the last 2.5 years and the last 9 months I've been unable to work. Your clinical approach is going to be very, very different. So that is actually the third leg of the multidimensional clinical profile. The fourth leg is there any comorbidity? If this is a patient who has a history of severe depression or anxiety, or is clinically very worried, you will approach this more differently. You will be more readily stepping into a neuromodulator, for instance, as compared to peripherally acting agents. And number 5 in the multidimensional clinical profile is a measured physiological variable. For instance, this could be a patient in whom you have measured transit and actually seen, although this seems like a mixed pattern hearing, if we measure transit, this is extremely slow. And it makes you think that perhaps this patient is severely constipated. And some of the diarrhea might be overlap or reactions to intermittent laxative ingestion, for instance. And I think the multidimensional clinical profile reconciles the idea of having a diagnosis, the idea of taking some clinical pearls on board, and the idea of, wherever appropriate and available, putting on board also measurements of abnormal physiology or other factors that you can measure. These could be biochemical as well, could be markers of bile acid synthesis, for instance. And I think this is the way we're going to go forward. We'll actually see that the picture is much more complex, that mapping out within one diagnostic category, all these variables drive choices of therapy and outcomes of therapy. And I think this is the way to individualize. It's a modern word, individualized medical approach, but actually I think we will have this in functional GI disorders as well. I think that's our message for the future.
Yeah, and I echo that, and I agree with what Jan has said, and I think we should iterate, repeat what we are saying in the title, that we think that combining symptoms and biomarkers is probably the way to go, and we're not there yet for all the different diseases, but for some of the disorders we are closer to being able to really combine symptoms and different kinds of biomarkers, and I think all of us would like to move in the direction of defining our diseases, disorders based on what we can measure, potentially also together with symptoms. But in the meantime, we definitely need to evaluate the symptoms, because that's why the patients come to see us. And at the current stage, I think it's the best way to do it, but hopefully in the future, also combining diagnostic classifications with the inclusion of biomarkers as well.
Great, and thank you so much, Magnus and Jan, for providing this perspective, and also for contributing to this discussion for Neurogastroenterology and Motility Journal. I think it's important to have these discussions periodically, so we realize that the differences that we have among groups may not be as big as we think. They're in fact thinking the same thing, just different ways of approaching it and different ways of applying them. And so looks like the future outlook is still very optimistic, and we think we're going to be able to do good things. And I really want to thank both you, Magnus and Jan, and also Michael Camilleri for contributing to this discussion and bringing it out for our readers so that they can themselves evaluate these issues. Thanks again. And of course, I want to thank our listeners for tuning in to another issue of our podcast for the Neurogastroenterology and Motility Journal. Thank you.
Thank you.
Thank you.
Welcome to this podcast from Neurogastroenterology and Motility. It publishes original research and topical reviews on basic and clinical aspects of gastrointestinal sensation and motility, as well as brain-gut interactions.